اوكي. السلام عليكم.
عليكم
وعليكم
السلام
السلام
دكتور
ورحمة
محمود،
الله.
كيف الحال؟
يعطيكم
حياك
العافية.
الله.
أهلين أهلين.
يا
How
أهلا
are you,
وسهلا.
Dr. George?
How are you
أهلين.
doing? Good to see
Okay,
you
very
again.
well. Thank you. Nice to see you. Yes.
اوكي دكتور، اوكي ماشي. Can you check please? لو
شوف الدكتور مجدي، شوف الرئيس.
احنا بندور على الرئيس.
ما أنا عارف. يعطيك العافية.
مجدي. it's connecting.
يا رب.
Okay, we then just 2 minutes more. We will start, Fahad. Okay.
No problem.
إيش الصورة اللي وراك يا دكتور فهد؟ هذه الصورة حلوة باين.
هذه أحد البيوت في صنعاء،
أيوة أيوة.
فخلاص يعني للأسف يعني إن شاء الله الوضع في اليمن تتحسن. بس اليمن جميلة وشعبها جميل.
أنا عارف. تعملش دعاية لليمن، أنا أخبر فيها منك. رحتها في الأيام الحلوة يعني.
ما يعملش
صدقت.
دعايه ليه؟ ما لازم يعمل دعايه، ما يعملش دعايه ليه يا دكتور
أهلين
محمود؟
أهلين يا دكتور مجدي، شوف نستنى فيك يا
اهلين
رجال.
اهلين. وانا
فيك
جوه، انا جوه من بدري، انا في صنعاء وجيت عليكم على طول.
أهلا وسهلا جوه.
اهلا بيك.
أهلين، نورت.
ربنا
أهلين.
يخليك.
نورتنا يا بروفيسور مجدي، أهلا وسهلا.
الله يخليك. ازيك يا
دكتور محمد بطل يعمل إشي من غيرك يعني.
الله
هو
الله
الرئيس،
الله
الرئيس
عليك.
احنا بنشتغل معاه يا باشا.
ما بلاش
نشتغل
الرئيس دي، انت شايف الامور مش حلوه.
يا
الامور
سيدي
مش حلوه.
تلبق لك تلبق لك.
من
ماشي.
بقلي
Okay.
شو أنت يوم الجمعة
Okay,
بتشتغل
Dr.
ولا
Majdi, we
بريح؟
can start because we are
انا
already
we
waiting
can
for
start.
you.
انا جاهز.
طيب ماشي. السلام عليكم ورحمة الله. Dear colleagues and friends, welcome to MEOM webinar meeting. After the conference that happened last week, the first Press MENA and fifth MEOM conference. And today it will be a recap just to highlight a certain point in the scientific program and also what happened during that conference. And before we go to recap, we have my dear colleague, Dr. Fahad Kohel, and he will give a talk in about faricimab in DME and AMD. And Dr. Fahad, the mic with you, please.
Again, Mohammed, thank you for the kind invitation. Really glad to be joining you again on the MEOM webinar forum. You need to stop screen share that. Sorry, thank you. So thanks again.
If we can mute all, please, so we can keep the Fahad only.
So I'm going to be talking about faricimab and its efficacy and durability in neovascular AMD and diabetic macular edema. For those of you who don't know me, my name is Fahad Kohel. I'm a consultant ophthalmologist at Morford's Eye Hospital here in Dubai. So why do we need a new drug? Why is a drug like faricimab developed? Because sometimes, particularly with the first generation of anti-VEGFs, the real outcomes for patients with neovascular AMD and DME differed from the clinical trial results. We weren't able in the real world to give the frequency of injections that was necessary in order to get those excellent vision outcomes. So if you look in the real world settings, because you end up giving lower or fewer injections, it leads to suboptimal gains in vision. In contrast, when you look at the randomized controlled trials on the left-hand side, when you're giving more injections, you're getting greater gains in vision. And we're not able to kind of meet that in the real world. That was either with ranibizumab or with aflibercept. So it was understandable that pharmaceutical companies wanted to develop something different, something better, something that's potentially more durable. And faricimab is one such molecule that has a kind of a bispecific antibody that has an anti-VEGF aspect to it, as well as an anti-Ang2 aspect to it. So you have dual inhibition of two important mediators which are upregulated in disease, leading to breakdown of the blood-retinal barrier, as well as neovascularization. So obviously we're all very familiar that VEGF upregulation leads to breakdown in the blood-retinal barrier. However, Ang2 overexpression leads to obstruction or inhibition of the Tie2 pathway, and that kind of accelerates the VEGF-induced permeability that you see in disease. So we know from human vitreous samples that Ang2 levels are overexpressed or is upregulated in patients with pathological conditions such as vein occlusion, diabetes, and AMD. And we know from animal models that Ang2 acts as a facilitator of VEGF-induced vascular leakage. So if you look at this bottom slide here in an Ang2 deficient mice, when you give VEGF, you get an amount of leakage. But when the Ang2 pathway is working satisfactorily, you get a greater amount of leakage. So you get a certain amount of leakage or breakdown in the blood-retinal barrier with VEGF, but with Ang2, you get an acceleration of that extent of that vascular leakage. So it makes sense to suppress both the Ang2 as well as the VEGF components of the disease to reduce the leakage as much as possible and hopefully improve anatomical outcomes and ultimately improve vision. This is another animal model where, again, if you induced CMV in a monkey with laser and you gave antibody, you had no, just antibody alone without any anti-VEGF or anti-Ang2, you had no impact on the leakage. And then if you give anti-VEGF, you get a reduction in the amount of leakage, but you get the greatest reduction in the leakage when you suppress both Ang2 and VEGF-A. So you can understand why Roche, in its wisdom, thought it would be a good idea to develop a molecule with a dual inhibition effect. So I want to share with some new data that was only published in the American Society of Retina Specialists meeting in July, and it was published as a free paper. And it's further exploring the pharmacodynamic properties of faricimab and comparing that with aflibercept. And what they did was to try and characterize the extent and the duration of suppression of Ang2 and VEGF-A in the aqueous humor of patients with neovascular AMD or diabetic macular edema treated with either faricimab or aflibercept. And basically, they took samples from the aqueous humor of a subset of patients who were treated with faricimab and aflibercept throughout the study. And what you can see is obviously you get VEGF suppression with faricimab that kind of only kind of increases kind of at around 12-week mark, which makes sense because you end up wanting to give a further injection at that point. And the same with diabetic macular edema, there's good VEGF suppression at 4 to 8 weeks, and then it slightly increases at 8 weeks to 12 weeks. Same can be said, though, however, for Ang2 suppression, that you get really good Ang2 suppression in both neovascular AMD and diabetic macular edema up to week 12, and it's only week 16 that the expression begins to increase. But this feature of Ang2 suppression was only seen with the faricimab, with absolute suppression of expression at week 1, 4, and 8. However, with the aflibercept, Ang2 was still identified within the aqueous humor. So actually, anti-VEGF suppression is not enough to, anti-VEGF suppression on its own does not lead to Ang2 suppression. It really has to be a dual action molecule that leads to anti-VEGF as well as anti-Ang2 suppression. So very quickly, let's turn our attention to faricimab in macular degeneration. So when you look at the first 12 weeks, where each group, be it aflibercept or faricimab, they got loading doses in a matched fashion. You can see in the faricimab arm, there's a slightly greater anatomical outcome compared to Eylea, with a greater degree in the absence of subretinal fluid or intraretinal fluid. So we think suppression of Ang2 as well as anti-VEGF, you're getting a greater anatomical or drying effect of the macula, and it's demonstrated when you look at the matched phase of the Tenaya and Lucene trial, and you're comparing Eylea and faricimab in a true head-to-head fashion. And as you can know, we have now published the 2-year data, and even with using faricimab in a treat and extend fashion, you're maintaining vision up to 2 years with no difference between the two arms. But the key thing is, after week 60, you're only giving 3 faricimab injections in comparison to 6 Eylea injections, with very low intraocular inflammation rates comparable between the two arms, with no cases of retinal vasculitis or occlusive retinal vasculitis. And again, 80% of the faricimab treated arm were maintaining either Q12 or Q16 by year 2. So I'll just show you a quick case. 70-year-old gentleman of Iranian descent, presented with vision loss in his right eye, long-standing reduced vision in the left eye. His vision is 0.34 in the right, 0.96 in the left. Diagnosed with neovascular AMD in the right eye, disciform scar in the left, and he's a self-paying patient. Between August 2017 to June 22, he's getting 28. He's already received 28 Eylea injections, so an Eylea around every 8 weeks. But due to persistence of disease activity, he was getting an Eylea every 8 weeks, and his vision was being maintained with that at 0.34. He was remaining independent, and I meet him for the first time in June 2022. So let me show you his OCT. So we're just going to go through the OCTs slowly. So this is during the Eylea phase. So he's getting Eylea every 8 weeks, but as you can see, the fluid is persisting. The fluid is persisting. So although Eylea is maintaining vision, it's not giving the anatomical improvement. And we know the drier the macula, the more likely you are to maintain those vision gains and maintain vision stability. And it's because you're reducing the distortion on those retinal cells. So then I meet him in June 2022. He just received an Eylea injection 8 weeks prior. Although his vision was stable, I still felt there was a marked amount of fluid. So at that point, we make a decision to switch to Vabysmo, and this is him after the first Vabysmo injection. So although the vision didn't improve, because at this time he has developed photoreceptor loss because of that persistence in fluid, but this was the first time we actually got some anatomical reduction by switching from Eylea to Vabysmo. And that was kind of maintained and improved upon as we continued to inject with Vabysmo. He got a slight recurrence because he delayed an injection by a couple of weeks. But once we gave him Vabysmo in a kind of 8 to 10 weekly fashion, I felt that we were able to get better anatomical reductions in the long term. And I'll just skip a few slides, but this is him at the last few visits. Really nice maintained anatomy. And really, it has been Vabysmo that's kind of made the difference to his anatomical improvement. And hopefully with Vabysmo, we have a greater opportunity because we're getting better drying of the macula to maintain his vision at 0.34. So his treatment history after Vabysmo, he's received now 12 Vabysmo injections over the last 16 months, but is now on the Q10 phase after initial loading phase with stable vision and anatomical outcome, no intraocular inflammation, and vision is at 0.35 in the right eye. So quickly, faricimab in diabetic macular edema. So again, we know from the pool data, patients on the faricimab treat and extend arm at 2 years were getting similar levels as patients on the Q8 weekly arm. But in year 2, the median number of rejections is 3, as opposed to 5 in the Q8 weekly aflibercept arm, and 80% of patients on the treat and extend faricimab arm receiving more than 12 weekly dosing, which is remarkable. And more patients achieved absence of intraretinal fluid and central subfield less than 280 with faricimab as opposed to aflibercept by year 2. And as you can see, 48% of patients getting patients with absence of IRF, and again 65% of patients getting CST of less than 280. So again, very quick case of diabetic macular edema, 74-year-old gentleman, Emirati descent, presents with vision loss in the right eye. He had had previous Eylea at another hospital. He was fatigued with the burden of injections. Presents to me in August of 23 with 0.62 vision in the right eye. Sorry, August of 22 with 0.62 vision in the right eye, camp fingers in the left eye, and I diagnosed him with central involving edema of the right eye. This was his Optos photograph showing previous panretinal laser. And this was his OCT at baseline. And we make the switch to Vabysmo. So initially, and his vision was 0.62. He gets a loading dose of Vabysmo, but as you can see, he got a marked reduction in the macular thickness. And he got the first 4 injections every month. But then we started extending up to about 12 weeks. So he got the 5th and 6th injection 3 months apart, with maintaining the vision and anatomical reduction with no recurrence of the macular edema. But I kept him on a Q12 weekly treatment dosing regimen because I was very concerned, because he was his only eye, to avoid recurrence of macular edema. And then finally, in the last few minutes, just again present some new data that was presented recently at Euretina last month, that faricimab reduces macular leakage to a greater extent in comparison to aflibercept in patients with diabetic macular edema. So again, it's just trying to demonstrate that there is some added benefit to our patients from that dual inhibition as opposed to anti-VEGF inhibition by itself. And again, they were looking at macular leakage and they were evaluating it during the matched head-to-head dosing phase of Yosemite and Rhine. So it's at this beginning phase of the trial where Eylea as well as faricimab was given at a similar dosing regimen. And they were looking at the macular leakage area as assessed by the Wisconsin Reading Center. And basically, the median area of macular area of leakage was vastly reduced in the faricimab arm by about 53%, and that was statistically significant. And this is just an example of a patient where at baseline you've got marked macular leakage. You give them the 4 doses of faricimab, the macular leakage is abruptly controlled and reduced, and so the blood-retinal barrier is stabilized with excellent restoration of the macular anatomy. But this head-to-head trial showed that faricimab was superior in the resolution of macular leakage in comparison to aflibercept. And with that, I will stop. And thank you very much for your attention.
Thank you very much, Fahd, for this very interesting and excellent presentation as usual. Few questions because we have few minutes for discussions, please. My first question, I want just to brief us how we are treating, what is the loading dose in diabetic macular edema and what is the loading dose in AMD, just to remind and refresh our information when we are using faricimab.
So for me, faricimab is, I give it every month for the first 3. And then after the first, in both AMD and diabetic macular edema, and I don't quite follow the label. And then after the first 3, I'm starting to think, can I extend this patient? And some doctors may go and extend by a month, but I'm more cautious and I extend by 2 weeks. But certainly after the third injection, third monthly injection, I start to plan the extension of the injection. And what I tend to do, I'll see the patient 4 weeks after. And if I feel that the disease activity is good and the vision gain is good, I'll schedule the injection 2 weeks after that and try and get them into that extension phase at an earlier time point.
What is the, I mean, I was asking not what you are doing, but what is in the leaflet and what is the recommendation by the medicine
I will
itself.
have to check that. I apologize.
Okay, Majdi, you have any information or Dr. George?
I was in Greece last June in Roche Paris-MAP meeting, and there are big discussion about loading dose. That's everyone's habitual doing 3 injection in 3 months, but many people advocate that we should just inject once and try to see if it's dry. If it's completely dry, we just follow the patients with extension, not necessary to complete the 3 dose. But if it's not dry, you should continue until dry, the 3 dose.
So,
I mean, what I mean,
Mohammed,
yes.
on the label,
Yeah.
you've got to do monthly for the first 4 doses, then you can individualize after that for both AMD and for DMO.
It is the same.
It is the same.
Not every 6 weeks in the beginning.
No, 6 week is the BOView.
Yeah, just I want to make this one sure because so many confusion about this one. So okay, that's what that is the aim. My questions, because in faricimab we have to use every 4 weeks, 3 doses in AMD and 4 I think in DME, right? Or 4 and 4.
4 and 4. So there's no difference between either arm. You know, monthly dose for the first 4 doses, then you can start to individualize. But I personally start to individualize sooner. But you're absolutely right. In BioView, in AMD, it's every 4 weeks, and then for DME, it's every 6 weeks. And we don't want to confuse the two.
Yes. Okay. You have any other comment from here, Dr. Majdi or Dr. George or any of our colleagues if they have any questions? I'm asking those they are specialized in the retina, but anyone in the even glaucoma, pediatric, oculoplasty, if they have any questions regarding this point, we are welcome. They are welcome. Okay, I have one question, Fahad. Now, when you are treating the patient, so now we are thinking, who is now the first line of treatment after now? Because before we are saying Eylea is the most recommended to be the first one. Are we now talking about that faricimab is the first line of treatment to be chosen, or we are keeping only to switch after using Eylea or Lucentis?
So in my own practice, I am using Vabysmo first line. So I have quite a few patients who I'm treating with a Vabysmo first line. But at the same time, I'm also using Eylea first line as well. But I'm kind of looking at the patient, and if I'm feeling that this patient is probably not going to able to cope with the burden of injections with Eylea, then I may be offering them Vabysmo sooner. But certainly my switch patients, I am definitely going from Eylea to Vabysmo, and possibly even with with severity. Now that we have greater insight and greater understanding of the benefit of the dual inhibition, possibly I may offer patients where I've seen greater maybe macular leakage at baseline, greater severity of macular edema, I may be erring towards Vabysmo in the first line. But I do use both Eylea and Vabysmo equally, to just so the audience is clear and for the sake of transparency.
Okay. You have any comment, George, about that?
I have one question. Looks like the Vabysmo is much effective to treat when you have epithelial detachment, pigmentary epithelial detachment. It's much more effective to use Vabysmo in comparison with Eylea. In your practice, this is really happen. What's your experience?
So I had one case. So there's so obviously we don't have as much AMD in this part of the world as say in Brazil, but I've had a couple of cases where it was one eye. I was treating them with Eylea, and although the fluid didn't recur, the PAD increased significantly whilst they were on Eylea. So when I switched them to Vabysmo, I was like, just as you experienced anecdotally, there was a good reduction in the height of the pigment epithelial detachment. However, I could not tell you what scientifically from Tenay and Lucerne, what that evidence base was and what the difference was between the two groups. But certainly anecdotally, I would agree with that observation.
Thank you very much, Fahad. I think I know you are also you are having another meeting, so a very busy guy.
I apologize.
We can move to our next part, which is the recap about the 5th MEOM and First Press MENA conference that was done during the last week on 19 to 21st of October. So before we move, I will ask Soria, please, if you can show us the video, please. Thank you very much, Soria. This is just a summarize of or few shots of the conference video, small short video, just to show you. And I will start today. Our aim from this meeting is just to highlight the scientific level and what we have shown during the conference. And I will move from different subspecialty one to one, and I will start with Dr. George, if you allow me. Dr. George, if you can, we can show with you can you share with the scientific program for the retina so that can Dr. George have an idea about it and remind. So we are having a surgical retina sessions around 3 or 4 with one round table discussions. And we are having discussions, different types. So if you can highlight what is the things that you find new or attractive for you during the conference.
Wow, the MEOM was so many things attract. I could not have time to catch all the meetings because it was so much information, so much sessions. And this session was very special, was moderating this session. Was huge session, so many cases, so many good cases. And I'm gonna highlight one big discussions about do vitrectomy, for example, for macular hole, and prophylactically laser the periphery. Very few people still laser at the end of the surgery, but the majority of people think that's the best way. Treat only if you have any lesion like retina tears. If you don't have this kind of thing, we don't need to photocoagulate these patients that's we just finish a macular hole. And then this is something that's majority of people are using. Another big discussion was to do core vitrectomy or complete vitrectomy, as we are trying to explain, in a surgery for epiretinal membrane. And the majority of the people advocate that we should do complete vitrectomy, even if you have only a epiretinal membrane to take, because sometimes if you have too much vitreous in the vitreous base, can contract and make a tear, and you have retina detachment afterwards. And whatever more was very discussing. Many people discuss what the best approach for diabetic vitrectomy. And after all, we think that the new vitrector machines helps a lot, and we can shave and the majority of the membrane, but we still also need bimanual surgery. In many cases, bimanual surgery is very safe, and you can use a lot, and you're gonna be a very good result. And another discussion was vitreous substitute, what we should use in diabetic case, for example, that's are very ischemic. And we agree that use gas is the best option, because we have very less complication compared to oil. Oil we're still using in case that we have a lot of iatrogenic breaks in the retina, or if you have only eye, the patients need to fly or go for high mountains, but we should not use so many things. But anyway, so many things happen, so many good science, and if I stay here all day speaking this, but let others say so beautiful things about science in the MEOM.
Thank you, George. I will show you one video, and I want you to comment about that, please. Can you show us, please, the video? Not this one. No. Third one. I mean the other video I share with you.
This one's so good that he loves to replay the music, the pictures, so many beautiful people. That's the beauty of the good meetings.
We will share the photo soon in the Facebook page of MEOM Academy. It will be all there by day per day. Okay.
And then we love to see the pictures of the good friends and good moments we have together. And
Sure.
It's good to remind.
So that video is down from the Spotify now, sir.
Okay, so I will ask you, maybe you can play it from your side, George, if you have it, the one you make a meeting with Mario. So I want to ask you about this one, to highlight about this, because this is the first time we are, presented this innovation by Mario. If you can talk about the innovation, and at the same time.
This is a topic that we spend a lot of times discussing. That is a great idea. We are discussing about the geographic atrophy treatment. That's something new for everyone. We just had some new drugs that are gonna block the complement C3 or C5. That is one of the multivariate factors for induce geographic atrophy, this inflammation. Another factor is the vascular. The ischemic of the choroid can induce the geographic atrophy. And Mario and his colleagues has a great idea to perform magnetic resonance contrast and check how the the fluid, the flow in the artery, ophthalmic artery. If this flow is below 50%, they go and dilate this artery with angioplasty, and then can improve almost 100% the flow in the choroid, and you can measure that the choroid start to be thick again. And he has a protocol. They're doing some patients, the pilot study, and he claimed a lot of good results. Some patients improve 2 or 3 lines after 1 month of the procedure. It's something really new. We really don't know how this new idea will really help, or has some other factors that are helping the patient. But it's really something new idea, break idea that's can change a lot our approach for geographic atrophy. I'm really impressed with this idea. Record interview with him. If somebody wants to check, I can send. But I'm really anxious to see more results and see how these patients are doing in the long run, if they skip with the vision that they claim to gain. It will be great thing for science and for the world. But this is the idea: arterial angioplasty in patients with geographic atrophy, a new possibility of treatment.
Yeah, I think this is the first time he announced, and during our conference, I think this is the first.
Yeah, well, for the first time in the world, he just started this protocol last August. He has 4 patients already, and the first conference he just showed the result was here in Dubai.
Thank you very much. It is working now, Surya, the videos, or not?
So that is an audio file. I will play it soon.
Okay. If you can show, it's okay. Otherwise, we can move.
Yes, I'll show it.
I'm George Rocha. I'm from Retina Hub, and today I'm here in Dubai in the MEOM meeting with my friend Mario from Argentina. He just finished a great talk about angioplasty as a treatment for geographic atrophy. My friend, tell me a little thing about this new idea.
First, thank you for inviting me for this famous podcast. And I'm telling you, we know about geographic atrophy. We have focused on complement and drugs to block the complement. And that is a new thing in the world. But now we have a different idea, a different approach. We found that many patients with geographic atrophy have some occlusion in the ophthalmic artery. This is very complex. They're using a very specific MRI or whatever it is to know for this podcast, but we can assess those patients. Finally, when we realize that they have some level of occlusion, we can go with a catheter and insufflate a balloon and dilate, this and angioplasty of the ophthalmic artery, especially the very first part of the artery. And what is amazing is that we are having, even when we have preliminary results, we are having very good results about it with patients even improving vision, not just keeping vision, like improving vision. But that's just the whole thing in 1 minute, 1.5 minutes. Explaining all the whole story, but you heard the talk. It's a lot more complex than that, but this is something promising. We are very enthusiastic about this.
That's amazing. It's a new idea that's improved the oxygen in the choroid. That's gonna be the more one chance for the patients to have better results in this untreatable so far disease that right now we just start to use in the block of C3 and C5, but this new idea can add more one possibility. And how you select patients?
Well, that we take these patients with we are running a pilot study, so we have very strict limits to include patients. We are expecting to make 20 patients at the end of the year. Wow! But these patients, the most important thing is just they have to accomplish some level of vision, and but the most important thing is imaging. First, they go to the MRI, and if we try to check that they have occlusion, they go to the procedure, which is with the total anesthesia, general anesthesia, and first we do an arteriography, so we can see better. With arteriography, we could be very precise if they have an occlusion, and if they got in, we put the catheter. When I say we, it's me. It's the neuroradiologist.
Thank you so much. I think this idea can evolve, and we're gonna have a wonderful result with the new patients. Thank you so much.
Thank you for the opportunity tonight.
Okay, thank you very much. Thank you, George, for the highlighting about different subjects and topics that happened during the conference. We can move now to pediatric ophthalmology. We have Dr. Hiba Mutwalli with us. We are glad to have it with us also during the conference. Can you share, please, the topics or the sessions that happened during the conference?
Good evening, everybody. Can you hear
Doctor.
Actually, it was a very successful meeting, and I'd like to thank all the organizers for their kind invitation. In the pediatric ophthalmology section, we discussed, in addition to the strabismus and complicated cases and management of strabismus by expert ones, and Dr. Sayhan Oskan from Turkey, Dr. Ibrahim Al-Adawi, myself, Dr. Hayat Khan, Dr. Raed Shatnawi, Dr. Ihab Al-Babli. They are very expertise and the expert in their specialty. In addition, we discussed many important topics, and I think pediatric ophthalmology needs updated topics in those subjects, updated researches and conferences to discuss such important topics like the gene therapy for inherited retinal diseases. I think the ophthalmologists should have some knowledge about this very important and rising topic all over the world. Maybe in the next MEOM meeting we discuss an actual trial in the Middle East on those inherited retinal diseases and the results of the ongoing researches all over the world. Also, we discussed the new technologies in the management of amblyopia by computerized programs. Now it is still rising and ongoing. We have also only two softwares in the world, and hope next meeting we announce that we had more knowledge and more experience with such technologies, and we concluded that the patching in amblyopia therapy, which is a very important answer for a very important question in the pediatric ophthalmology world, whether all these technologies is an alternative or an alternative for the patching therapy and occlusion therapy in amblyopia or not. We discussed also the updates in the lenses used for IOL implantation, used for in the pediatric cataract, and the useful tips how to rescue lost muscles. In addition to all previous topics, I was very very happy and impressed that we discussed very important topics in the retinopathy of prematurity, and we had a very important guests from all over the world to discuss this very critical problem and serious problem and vision-threatening problem in the neonates. And I hope next meeting we discuss more and more important, very important topics in the pediatric ophthalmology, in all the pediatric ophthalmology subspecialties.
Thank you very much, Dr. Hiba, for this insights about the meeting during of pediatric part. Just one question, Dr. What are the most topics that, I mean, that's it's kept in your mind, or you take it from the conference in pediatric subspecialty?
The most important topic that I hope that the softwares that help treatment of amblyopia is available and accessible to all patients all over the Middle East countries. I think it is still very expensive, and not everybody can afford to have this treatment for his children. This was very attractive for me. Also, the management of myopia all over the world in pediatric ophthalmology, there are many trials to help control the myopia, which is increasing among our children due to prolonged periods of near sightedness. And I think the control trials is very important. Also, the gene therapy, I was impressed by the number and the huge number of studies that are ongoing in all the inherited retinal diseases in the world nowadays.
Thank you very much, Dr. Hiba, for this conclusions about the meeting and the scientific level of the pediatric ophthalmology during the conference. We are happy that and glad to have you and have many eminent speakers from different parts of the world, and from Turkey, from Egypt, from another part of the world. So thank you very much, and we hope to see you, inshallah, in the next year, inshallah.
Thank you.
So we can move now to Dr. Mahmoud Salam. He will give us information and brief about what happened during the conference in the field of oculoplasty.
Hello, everyone. My regards. Actually, we had 4 sessions, 2 proper sessions in Hall B and Hall C, I think. And one is about the orbit session, tips and tricks on the orbit. And it was very fruitful session. The other one was aesthetic last day, and it was both of these sessions are well attended, and we had a lot of participants from the United Emirates as well. We had also one instructional course that was very good, but unluckily it has to be shifted from Hall C to Hall D. Somewhat.
We can talk about this later on, Dr. Mahmoud.
Later. Anyway, that was we started late, and okay, and this is but it was very beautifully prepared. It was very good, and yeah, it was well attended, and actually very fruitful. And we had also a round table discussion about unusual cases in lacrimal surgery. I prepared the cases actually. And we were unfortunate actually to have, we didn't have any guests of oculoplastic ourselves. I compare the pediatric people or whatever, because we are the MEOM people, me and Dr. Farzad mainly, and one from Jordan, and
Dr. Mahmoud, if you allow me to interrupt you, what are the topics that you think it was attractive you and was
Well,
presented during the
the
conference.
orbital cellulitis مثلا يعني by one of our colleague with the mucormycosis. It's very nice, but well prepared.
What are the I mean anyone he presents something that يعني unusual and you find it something يعني attractive for you and you remember
I
it.
myself presented six presentations. I know what I have presented. Actually, what
I mean from the other colleagues.
About the thyroid, we did very nice work. Dr. Farzad he presented about immunoglobulin G6 disease, orbital disease. That is very good and well prepared. And also orbital floor fracture by Saber Karma. This is one topic. But there is and the unusual cases were good brainstorming. We met very nice colleague Walid Abdullah. Really he had very nice contribution. Dr. Ala Sadaqa, okay, and Dr. Khalid from Emirat. I don't remember. You remember? He is in the
Khalid Ibrahim Al-Khayyat.
Khalid Ibrahim Al-Khayyat. Yes, he is in Moorfield. كأنه Moorfield.
Yes.
Okay, he did very well. He presented about the DCR laser management.
So there is a variety of topics that was discussed during the meeting, and and we cover most of the topic, I think.
It was nice. Of course, oculoplastic surgery or orbital surgery is a vast subject, and actually, what we just shown the most important things that really the general practitioner or the ophthalmologist will see and be confronted with. We don't want to make it very deep.
For today, I think it's more that we want to have only few points about every subspecialty, and I think it's well mentioned, Dr.
Otherwise, it's okay, fine.
Thank you very much, Dr. Mahmoud. Thanks a lot.
I'm glad to hear from Dr. George that you had a breakthrough announcement about a certain treatment for the geographic choroidopathy, and that's very great, very good for the MEOM. شكرا يا دكتور محمد. Okay,
thank you very much, Dr. Mahmoud. Dr. Yasmin, glaucoma. Can you share glaucoma, please, topics?
Okay, so this is a short recap, but before I start, I'd like to express why I love attending the MEOM meeting every year. It's one of the very special meetings to my heart. The scientific content is very rich and the atmosphere is very friendly. I'd like to thank all the organizers and of course Dr. Muhammad Al-Amri for orchestrating all this. His high spirits are always contagious and we're always like laughing and learning and making new friends and meeting people we haven't met for a long time. So the glaucoma was basically the glaucoma sessions, there were 3 of them, and there was a roundtable discussion that was mostly focused on angle closure and its management. It was moderated by Dr. Winnie Nolan. She's a consultant glaucoma consultant in Moorfields Eye Hospital in London. She's very specialized in angle closure in particular, with a lot of publications. And the discussion was really rich in the sense of looking at all the controversies. You know now how we're treating angle closure, basically addressing the lens itself and doing more and more phaco to treat angle closure. So we discussed what type of cases and what level of glaucoma we would treat with lens extraction. We discussed all the recent studies, the EAGLE study that suggests doing clear lens extraction for angle closure patients, and how the inclusion for this study was basically patients over 50, but we are extrapolating this to even younger patients. So we discussed our experiences with doing clear lens extraction in younger patients with angle closure, how we're limiting the prophylactic PI for patients who have angle closure without glaucoma. According to the ZAP trial results, they found that it's better to wait and not do the PI because the risks are very minimal in leaving patients with angle closure. Just following up would be enough. One of the very important sessions that I learned from and exchanged knowledge with the colleagues in glaucoma was the instructional course on minimally invasive glaucoma surgeries. You know how MIGs are more or less replacing or adding more to the armamentarium of glaucoma surgeries that we have. But the great news was that we almost all agreed that it's replacing a lot of the procedures of glaucoma in even advanced cases of glaucoma. So we may choose to go for GAT or KDB, Kahook Duoblade for patients with advanced glaucoma, whereas MIGs were always thought of as minimally invasive, minimally effective, or less effective procedures for mild to moderate glaucoma. It seems that there's more encouragement to do them from the results we see and the evidence and what we see in our own patients to use them in more advanced glaucoma. There were two other main symposia, one on the surgical nightmares, which addressed the different complications of glaucoma surgery. There was a talk about hypotony and managing it by Dr. Bassel Faouri, cyclodialysis clefts and tube erosion, which are things we run into from time to time. And as we know, the management of complications is even more important than the procedure itself, because it's very simple to do the surgery, the same surgery over and over again, whether it's trabeculectomy or MIGS, but it's dealing with the complications that really influences the outcome and makes it a safer procedure eventually. And finally, there was what I think was an important session targeted basically to non-glaucoma specialists. So we addressed glaucoma relevant to the different subspecialties. Glaucoma for the cataract surgeon, for instance, angle closure and its role in treating, the role of phacoemulsification in treating angle closure. Glaucoma for the refractive surgeon, whether through phakic IOLs or LASIK and PRK. So which patients are suitable to do glaucoma, refractive cornea surgery if they're glaucoma suspects or early glaucoma. Managing glaucoma in patients who've had a phakic IOLs, how to prevent it with the proper investigations and proper measurements preoperatively, and then how to treat it if it happens, how to investigate whether it's open or angle closure. And then finally, glaucoma for the retina surgeon, the post-vitrectomy glaucoma, how it's managed, how most of us prefer doing tubes in these cases, and as well as the neovascular glaucoma as well. And finally, I presented on glaucoma for the pediatric cataract surgeon, how it's underdiagnosed, the glaucoma in these uneventful lensectomy cases in children who may develop glaucoma up to on average 12 years post-operatively. So it's very important to look out for these cases, to screen them, and to advise the parents of the patients who've had an uneventful lensectomy to continue to follow up their IOP for life, really, because glaucoma, they're at risk of glaucoma throughout their lifetimes, especially starting 4 years and onwards.
Thank you, Dr. Yasmin. Actually, you didn't give me any chance to ask you any question. You briefed it in an excellent way, as usual. I think we have Miss Dr. Mohsen. Maybe he's having some issue to connect with us. Dr. Mohsen Baqali, he was going to talk or to give a brief about the cataract and refractive and breast MENA, but maybe we can have him in the next recap. Maybe we can, if we can have Dr. Majdi. I don't know, Dr. Majdi, you are there? Dr. Majdi?
Yes, I'm here. I'm sorry, I'm in another meeting, but I'm here. I'm attending everything. Okay, you are. You can divide yourself into two parts, one with the other meeting and the other half with us. It's okay, acceptable. Okay, I'm dividing. Yeah. I'm dividing.
The brain with us.
The brain with us.
The brain and the heart. How about the heart? Keep the heart there. Keep the brain somewhere.
Okay, Dr. Majdi, I think you will brief it within 1 second. Okay, about the medical retina.
Yes, the medical retina was great. I was involved in every part in it, and I was happy to see how the surgical and medical were engaged in all the session. Even the case presentation, the doctors from the surgical retina, they shared very nice cases with us. And we learned a lot from the case presentation session because it's different cases, different ideas, different in everything. So I was glad. I was really glad about that. And we learned a lot from the case presentation. Also, the session with the update on CSC and other medical disorders, congenital disorders. We have a lot of information. So I was glad. And the best thing over there, the discussion. Everybody was engaged in the discussion. And this is good because this is what we need in the real life practice, to see cases, to discuss it, to learn from other people, to learn from other cultures. And this was good. So, and we have a course also. Everybody spoke about his sessions, but we have course and we have a nice imaging course over there. The attendee was good and the engagement was good. And this is what the conference for, to engage, to see cases, to discuss updates, and to see friends. And I was glad that a lot of people were attending from all over the world. I've seen friends from Athens, like Dr. Thanasius, Olga, and I've seen new people from Morocco, Tunisia, Iraq, Libya. I like seeing people, engaging with people. And this is the main thing in the conference is to see people and to discuss and to see how others work and how things work in other countries. So medical retina was great at all aspects, and we enjoyed that. And the discussion was great. And what I can say, we are looking for the next year, and we don't know what we will do in the next year, but I hope it will be much and much better and at the level of the medical retina. Thank you so much, Muhammad, for all the efforts you made. And I know you did a lot of things. We all worked, but you worked the most. And thanks for other colleagues sharing with us all their ideas. Thank you.
Thank you very much, Dr. Majdi. Okay, I think we have Dr. Nazim. If you want to say something before we can conclude this session today.
Of course, I didn't participate in any of this, but overall, I felt very happy to see the first day when we saw this refractive surgery press manner, and that was the big boom. And that's the first new thing that many people came to see. And that is what we need to do, innovation. In this meeting,
we are in every part of it. I mean, Dr. Nadim, we are trying to have innovation in every specialty.
Yes, exactly. And you know that we have been discussing it so much.
Yeah.
And
I think for the
everything
next
was
year,
good.
we are also preparing to have the new things, which you call it the new things. It will be in MEOM Academy. We start with breast MENA. Now we are going to the next step, which will be on, no, here it is. You can see the first oculotrauma MENA. So the first this one, another, well, let's say foundation, it will be done, and it will be next year another things to be added to the conference.
Only thing I would like to add is about we need to, I would love to increase the number of research papers being presented. So we need to work on that.
Time, Allah, Dr. Nadim, we find there is a lot of people they send, but there is no time.
I know that. I know
everyone.
that, but we can still do it.
We can do it, but I know so many people, they are upset because we are not accepting, but you know, the time is not enough, and there is, we can't accept.
We will do it.
Many we receive a lot from the research and paper, and unfortunately we have to select only a few of them because of the time, and the best that according to the committee. Thank you very much for all. And I would like to thank you everyone by his name, by his personality. I'd like to thank everyone who attend our conference. There is more than 1,500 attendees that attend our conference. There is a lot of papers, there is a lot of presentation. It was, I don't want to say because this one, it will be not, it should be listened from another one, but this is what they reflect from the people, I get it. There is a lot of friendship. There is, I mean, it was very warm meeting. Everybody is happy everywhere. We hope that everyone was happy with us. And we'd like to see every one of you in the next meeting in the next year, inshallah. So the next year it will be, we decide our meeting, it will be on from the 30th of October to 2nd of November in 2024. So this is going to be the MEOM 6. And next year we are having also something new that we talk about it, the first oculotrauma. So the trauma in, sorry?
It's a very good idea and good title for the next conference, Dr. Muhammad. I like the idea, and I think from now we have many topics in all subspecialties that could fit in the trauma MENA next year, inshallah.
Yeah, I think trauma, it's a big thing. I think we it's not well
covered,
tackles or taken by, or yani, all the times we are giving only one session. Sometimes we ignore it, but I think it is very important, available in different subspecialty. It can be in oculoplasty, in pediatric, there is a lot of things that we have. Even one time I was just, this is it's not my subspecialty or specialty, but one time I was requested to present a trauma in pediatric. It's by one of our colleagues. It's I tried, then I found it's a very big and huge things is running about this. When I saw the research, the abstract, and different, how they are dividing, how they are doing, what are the most important, the prevention. There is a lot of things that can happen in trauma. And so I think, inshallah, next year we will have a lot about the trauma and from different subspecialty. At the end of this meeting, I would like to thank you all. If there is anyone to say something, it's the last. Yeah, everyone is welcome. Before
I have a last word to comment. How can I do that?
Yeah. Dr. Majdi.
Yes, Dr. Majdi.
You have greeting from somebody from Gamboom standing next to me, because this meeting I'm in now is from Gamboom, and he's saying hello. Say hello. Assalamu alaikum.
Who's this one? This voice I can hear it very well. Ashiwi, Muhammad Ashiwi. Al-Basha Al-Kibir. Thank you, Muhammad. I think we have to thank all the sponsors, and special thanks for Jamjoom Pharma, and special thanks for Dr. Muhammad Ashiwi. He was very great support actually during the conference, and even Muhammad Saleh also, he was a very great support from the one who is running from Egypt. Really, it was a great. I would like to thank all other from Novartis, Bayer, Allergan, Roche, Amico, Alcon. There is a lot of company. I don't want to miss anyone, but I would like to thank you, all of them. Dr. Majdi, he put me in this point, and they are enjoying. See, they are eating and enjoying, and we are doing a meeting.
We are not eating. We are in the light and sound in Luxor.
Maybe after a while they will be dancing. Anyway, thank you very much.
They will compensate for the next year.
I think there will be an innovation that food can be transmitted through the Zoom. This is what I was waiting for. If they are going to transmit the food and everything, that it will be a great through the Zoom. At the end, I would like to thank you, Dr. Hiba. Thanks a lot for your efforts and support during the conference, and for your today, Dr. Mahmoud, as usual, one of the executive committee. Dr. George, thanks a lot. I know it's the time, I don't know, it's an early or afternoon, but all the time you are already there. And I would like also to mention that Dr. George was selected to be the personality of this year for the 5th MEOM, and he will deserve it. And we'd like to thank him for all his support. He was one of the main support for the MEOM, and not only for the MEOM, and for the ophthalmology worldwide. Dr. Yasmin, one of the star of the MEOM, and also for the glaucoma in the Middle East and worldwide. Thank you, Dr. Yasmin. Dr. Majdi, the president of the 5th MEOM conference and 6th MEOM conference. I'd like to thank you all. Thanks to Dr. Nadim, Dr. Ashraf, Dr. Safa, all the executive committee in the MEOM Academy, and executive committee in the Breast MENA, and advisory board of the Breast MENA, scientific committee for the whole programs. And for special thanks for those they attend the conference, and we hope to see you, inshallah, within few weeks in another recap. Good night. Assalamu alaikum wa rahmatullah.
يعطيكم العافية.
Thank you.
Thank you very much.